Okay, so I promised I would talk about the stroke patient that I lost. It was on my last travel assignment in San Antonio, and this patient came in from an outlying facility, and it was a rehab facility that was strictly paper charting. They did not do e-charting like most places do. So during this patient's nurse's lunch shift, she had a stroke, and they shipped her over to us around maybe 5:30 p.m. and she had no contraindications to the medication. She wasn't on anything that would cause her to have any damage. So with that being said, we immediately gave her medication. Family agreed to it. There's a lot of risk for that medication, of hemorrhaging, bleeding out, not working at all. But what that medicine does is it basically dissolves every blood clot in your body. So a lot of the contraindications to it are simple things like blood thinners if they're already on one, any recent fall, any GI bleeds, any recent surgeries. So those are all contraindications to that medication. But she didn't have any according to the chart and the paperwork that we were sent with. So we had a very limited amount of time to get this patient to CAT scan and get the medication on board. I was actually the shift change nurse for the patient. She'd already received her TPA. It was complete. I was just basically there to take her to ICU at this point. Well, before I could get her to ICU, she became completely unresponsive. Grabbed my ER doctor, we hurried up and intubated her and ran her down to CAT scan, and her entire brain was one massive bleed, and she had herniated. Both pupils were fixed. Basically, she was brain dead at this point. So we brought her back into the room, and we waited for all the family to arrive. And once the family arrived from all over, at about midnight, they requested that we withdraw care. And that's fine. We can withdraw care, but normally she would have already been in the ICU by now, and we would have sent her up there, but the family didn't want to. They wanted us to hold her in the ER until then. So the family requests that we withdraw care. So that's what you want. They know that we're not going to, she's not going to make it. They understand. She was in her 80s. Come to find out, she had been 2 weeks prior, had a syncopal episode and had a fall and hit her head, which we did not know about. And they had put her on Coumadin for new onset AFib, which we did not know about. So we take the breathing machine off of her. We turn it off. She died at 12:15 a.m. New Year's Day, 2018. Those kind of things stick with you because it was a very emotional day for us. But what had happened was the day shift nurse that was taking care of her at her rehab facility took her MAR out to pull the meds, but forgot to put it back in the chart, which we never pull anything out of a chart. You take the chart with you. Had pulled the med chart out to go pull her meds for the day. Well, the lady had a stroke while she was on her lunch break, and the nurse that recognized the stroke asked the CSR to make a copy of the chart to send with her, and we got sent the wrong medication list. So when I called to tell them that their resident passed, she wouldn't be returning, they were like, why would you ever TPA somebody that's on Coumadin? And my answer was simply, we didn't know she was on Coumadin. Our medication list is dated XYZ. And she said, oh, that's the wrong med list. She's been on Coumadin for about 2 weeks. So guys, pay attention when you're sending a patient out, because we have to go by what you've sent us. So if you're actually out there and you're sending a patient out and you're still a paper chart facility, there's not a lot of them left, but you want to pay attention and you're sending us the right information and the correct information for that patient, and it's the right chart, because we're trusting that you're sending us what we need in order to take care of this patient. So she died on us on New Year's Day, and I'll never forget it, because I stood around with the ER doctor and the entire family crying while we turned the machines off. She died 3 minutes later. Pay attention to what you're doing. Don't get in a rut. Don't get in a habit, because when habits happen and we just start running about our day the same way we do every day, we miss things. We miss those slight nuances that change your patient's life. And had we not TPA'd her, yes, she probably would have been paralyzed, and she probably would not have had a good way of life for the rest of what she had, but she also wouldn't have died on New Year's Day in front of her family, and it wouldn't have been a cause of us. What I want you to remember, that especially from my providers, my PAs, my nurse practitioners, my doctors, you guys, you write the prescription, you write the medication order. It's basically loading a gun. As the nurse, as the LPN, as the medical assistant, you decide if we're pulling the trigger. You have to remember that you're the person that actually caused the problem. And when you're the person that pulled the trigger on a medication that killed someone, you never forget it. I happen to not be that nurse that gave the medication, but I do know that it did sit on that nurse for a very long time, and she did not do. She had a hard time with it. So, as we all did, because we never want to lose a patient. We want everybody to get to go home happy and healthy. That's our goal. In the emergency room, our rule of thumb is, hey, we got to treat them and treat them. So we treat them for what's wrong, and we get them on to a different level of care besides the emergency room. So when we're wasting beds, or we're wasting time with someone that has a hangnail, we're missing the stroke, we're missing the heart attack, we're missing the gunshot wounds. You guys, use the emergency room like it's supposed to be used for true emergencies. If it's not a true emergency, that's what we have a billion urgent cares for. And that is what we have our primary care doctors for. So call your primary care doctor if you feel like it, but we don't mess around with things like heart attacks and chest pain. We don't mess around with things like strokes, or obviously any bleeding that you can't control at all. So you want to make sure that you're using the emergency room for the proper reasonings, because things like this happen because we just get into a hurry up and get them out of here role. And, I no longer work as a nurse. I stopped nursing in 2018 when my company took off. And that was one of the last patients that I saw over that time frame. So got several stories from San Antonio. I really enjoyed working at that hospital. But really sit back and think about it when you're that provider. Is this medication going to kill my patient? Because once I put this in their chart, that nurse may or may not give it. And nowadays, we're getting too many people that are too worried about scanning medication and not actually verifying it's the correct medication for their patient, which is why I call them grocery store nurses. You've got to pay attention, because you could be the one that actually causes the damage and kills that patient. And trust me, you don't want to be on that side of the chart. Y'all have a great one. Look out for the next test.